My name is Stephen Thompson, and I am a neurologist with the University of Texas Health Science Center in Houston. This presentation will be on the evaluation of patients for epilepsy surgery. There will be many other chapters and presentations that follow, and this is merely intended to be a broad overview of the topic. So the goal of epilepsy surgery is the complete resection or ablation of the epileptogenic zone. This is conceived as the cortical area responsible for the generation of seizures. So localization of this area and its removal should then palliate the patient of their seizures. The goal of the pre-surgical evaluation then is, of course, localizing the epileptogenic zone and secondarily determining the extent that it may overlap with a functional or eloquent cortex. Understanding these two components will allow the crafting of a safe and effective surgical intervention. There are various non-invasive techniques that are available. I will review the most helpful ones and briefly survey some of the ancillary techniques. Many of these cases, the majority, can go to surgery simply from non-invasive analysis, but we will touch upon cases that may require an invasive modality. So the overarching idea is the development of a clear hypothesis, if you will, as to the origin and localization of patients' seizures. How do they arise in the brain and produce the symptoms that they do, and where anatomically is that most likely to be occurring. There are many steps along the way in devising this hypothesis, and the three most important are the clinical semiology, the MRI, and the video EEG recordings. So to begin with, of course, the history is essential. One needs to understand very clearly from the patient or their family members what happens in the seizure, what is its semiology, that is the symptoms and signs of the condition. Many patients will be able to report an aura at the beginning of their seizure. This is simply the subjective component of the seizure, and typically the initial component. It's not a separate warning, if you will, as in other areas of neurology. It is truly part of the seizure itself. The semiology is going to be very critical in understanding how the epilepsy affects the brain and where the seizures are arising from. So is the first and arguably most important step in the process. There are many risk factors to recognize. Very relevant ones are febrile seizures. These are, of course, seizures occurring in early childhood life, which can predispose to the development of hippocampal sclerosis, a very common substrate for refractory focal epilepsies. Another important risk factor would be head injury or a CNS infection. Family history factors into this, and there are some genetic conditions that do predispose to, of course, generalized epilepsies and focal epilepsies as well. There are some genetic syndromes that are amenable to surgical intervention. The only patients who are appropriate for consideration, or at least the majority of patients to be appropriate for consideration, are going to be pharmacoresistant. That means that they are not responding well to their seizure medicines. By definition, this is being refractory to two or more appropriate and well-utilized medications. There are some instances where surgery could be entertained before this point is reached, but most typically that is the benchmark that's expected. Mostly because, of course, we're talking about a intervention with potential morbidity, and it needs to be justifiable. After history and semiology, The next step, and a very important component in the workup, is a good high-resolution MRI. Now, of course, MRI can be done at multiple field strengths and with varied sequencing, but a certain protocol is recommended to optimize the diagnostic value of the MRI. A working group with the International League of Epilepsy recently proposed guidelines that can be easily found online. The Harness MRI, which calls for at least 3 sequences. One is a volumetric or 3D T1 weighted sequence. This can, of course, be obtained in any plane and then reformatted to the other 2. The second is a 3D or volumetric flare sequence. And the third is a 2D coronal T2 weighted sequence that's generated perpendicular to the long axis of the hippocampus. It's often referred to as the coronal oblique. Here, for example, is a patient with hippocampal sclerosis. The coronal oblique would be generated perpendicular to the length of the hippocampus. So the slices are run in an oblique way, and it optimizes the visualization of the hippocampus down its length. In some cases, contrast is required, and really only if there are tumor or vascular abnormalities expected, or in the case of infection, of course. We should note, however, that not all lesions are equally epileptogenic, and not all findings on MRI carry the same weight. So, for example, patients who have had encephaloclastic lesion, possibly from an intrauterine or early childhood stroke, these are far less epileptogenic than, say, a focal cortical dysplasia. Also of importance is that the epileptogenic zone, that is the area producing the seizures, may well extend beyond the visible boundaries of the lesion. This can occur even in focal cortical dysplasia, where part of the abnormality is below the resolution of the MRI, and also related to the network architecture of the brain. But another example is simply cavernous malformation, where, of course, the abnormality itself is vascular and does not have any neuronal content, and then the epileptogenic zone, therefore, is outside of it, and possibly even quite remote from it. Another important thing to understand is that only part of the lesion may be epileptogenic. So, for example, in polymicrogyria or periventricular nodular heterotopia, or tuberous sclerosis, in all of these cases, the epileptogenic zone may be only part of the lesions, and determining this can prove quite challenging. So finding a lesion on MRI greatly simplifies the formulation of a pre-surgical hypothesis, but it's not required, it's not necessary, and it's not sufficient to advance a hypothesis. A good clinical methodology can overcome often the absence of an MRI lesion. And the other piece that's central to the pre-surgical formulation is surface EEG. Now, these studies are often obtained in an epilepsy monitoring unit where patients stay for a number of days. This allows for capture not only of long periods of time, but also the reduction of seizure medicines. The EEG, of course, is a very complicated signal. This example comes from that patient I showed you earlier with hippocampal sclerosis, where there is a clear left anterior temporal seizure rhythm that develops as the patient's clinical seizure ensues. So with these 3 pieces, with the anatomic detail of the MRI, the electroclinical understanding based on video EEG and described semiology, one tries to form a rational hypothesis as to what is likely going on. The data are integrated as well as is possible, and At this point, they may well converge onto a epileptogenic zone of high probability, and at which point a surgical strategy could be proposed. For example, a simple example would be that a patient with that left hippocampal sclerosis who has concordant semiology, let's say an epigastric rising phenomena followed by a loss of awareness and distal automatisms, and then an EEG that's compatible with mesial temporal lobe epilepsy. Such a patient really doesn't need any further workup other than neuropsychological assessment. Because memory, of course, would be very important. Memory and language abilities would be very important in surgical planning. At this stage, a surgery could be proposed, whether it be resective, the classical anterior temporal lobectomy, or ablative with various laser techniques. There are other ablative procedures that can be performed, but that goes outside the scope of this lecture. Now, of course, the data may not converge, and this is especially the case when the MRI is negative, when no abnormalities are apparent, and in which case many additional tests may be needed, and this sort of situation, this sort of case is very likely to progress to an intracranial evaluation. I'll briefly survey some of the diagnostic techniques that can be used in such cases, and these are ones that my center uses. There are many others. One modality that's very widely used is PET scanning, and FDG. PET scanning is the typical isotope with epilepsy, and it's very similar to PET scanning for other conditions. The hypometabolism that's looked for that can support an area of the brain that's hypofunctioning and is responsible for the epilepsy. Here's a nice example of a patient who has what's known as a bottom of the sulcus dysplasia. Looks, of course, a little bit unusual on MRI, but is very clearly hypometabolic on PET scanning. And this example shows a co-registration of the MRI to the PET, which is very helpful in cases like this, because without the co-registration, one doesn't understand the pattern of the gyration. The surface looks normal, but it's this deep-seated sulcus that shows the hypometabolic signal. Another thing that can be done with fused studies is a statistical processing, comparison to a normative data set, and a statistical weighting to highlight areas that may be statistically abnormal. In this case, it's visually apparent, but the statistical weighting also just backs up the situation. And this is a patient who has mesial temporal polar epilepsy. So this epilepsy involves both the hippocampus, which is also hypometabolic, as well as strikingly the temporal pole. Another technique that utilizes neuroimaging and functional nuclear medicine techniques is ictal SPECT. Now, a SPECT can be obtained in both the ictal and interictal condition, and the highest yield study comes about from a subtraction of one from the other. So a subtraction of the interictal study from the ictal study, leaving a difference that can be statistically weighted to yield regions of hyperemia. The study can then be co-registered against an MRI to determine where this sits in anatomic space. There are two examples shown here, both of whom have had prior epilepsy surgery. On the left, you see one area of striking hyperemia in the supplemental motor area. You see an area of resection that's anterior to that. This was an unsuccessful resection. And on the right, there's a patient who has a prior temporal lobe procedure, and you see an area of hyperemia that's posterior and superior to that. Now, the region of hyperemia needs to be understood within the framework of neural networks, and by itself doesn't provide direct localizing information, but is a very helpful tool for example, devising a invasive strategy. Another technique that is very useful, though less widely available, is magnetoencephalography. This relies on the magnetic correlate of the EEG, and this signal can be localized in the brain through magnetic source imaging to determine mathematically the most probable location of a given activity. Now, it is the interictal spiking that's most often used for this, and in the top row there is a study with the localization overlaid on the brain. These dots represent the probable source of the epileptic spiking that was recorded by the MEG. The bottom row shows this same localization against the post-operative MRI. This patient had a SEG performed and then the resection, as you see, and clearly in this case the magnetoencephalography was very helpful in localizing the area of the brain most relevant to this patient's epilepsy. This patient is seizure-free. Finally, but certainly not the last of the non-invasive techniques available, is just a further processing of the MRI. So statistical post-processing, and there are many techniques available for this. One fairly widely used algorithm was developed by Huberts et al. And is known as morphometric analysis program. It's based on it's a voxel-based morphometry approach where a signal is the MRI signal is kind of decomposed into its elements, and then those are compared statistically against a normative database. So this is a patient who has a dysplasia in the occipital lobe, and this is the so-called junction image, and then this is a probability score from a deep learning algorithm. There are also post-processing algorithms that can be applied to the hippocampus for quantitative volumetric analysis. There are various commercial packages that do this. So those studies are often going to be employed in patients who have a normal MRI, or for whom the typical non-invasive data do not allow for a clear hypothesis to be formulated. These are the patients who are very often going to go on to have intracranial invasive EEG monitoring, and it is really the minority of patients. Now, for this to work, one needs to have a good and sound hypothesis in advance. The brain can only be sampled so much, and if the electrodes are not adequately positioned, the studies will fail. So a rational hypothesis is necessary for success, and the flip side of that is to do a study without a sound hypothesis is akin to a fishing expedition, and it's not likely to work, and it only risks harm to the patient, so should be strictly avoided. There are a few situations in which an invasive evaluation is more likely to be required, and I've sort of alluded to one of the major ones, and that's where the MRI is negative, and or there could actually be a lesion, but it's just not concordant with the rest of the electroclinical data. So at the formulation of the non-invasive data, the data remain inconclusive, so one cannot reasonably justify surgical intervention because the data do not support at that point. Another situation that is frequently encountered is the possibility of multiple potential epileptogenic lesions. For example, tuberous sclerosis or the nodular heterotopia examples cited earlier. So in this case, the non-invasive data are simply divergent. There are too many possibilities and they need to be narrowed down. And the third situation, and it's usually not the only indication, is where the hypothesis involves eloquent cortex, in which case some sort of functional mapping is needed. Now, intracranial evaluations are almost never done only for this reason, and if all that is needed is functional mapping, many times this can be achieved non-invasively or through intraoperative recordings. So again, invasive evaluations are typically required when the data are inconclusive, when they're divergent, or when functional mapping is needed to define a safe surgical boundary. There are two major modalities of invasive monitoring, extraoperative invasive monitoring. The first is the subdural grid, or strip, which is placed in the subdural compartment and sits atop the cortex, and the other is stereoelectroencephalography, or SEG, which utilizes depth electrodes exclusively. So subdural grid evaluations are most adequate when functional mapping is needed in regions where one needs contiguous sampling and monitoring, and so especially in language cortex. SEG is another technique that was developed in France by Banco and Telerock in the 1950s. It remained a major technique in France and Italy, but was not widely used in North America until late, outside of Montreal. There's been a recent renaissance, if you will, in North America, and SEG is very fast becoming the preferred method, and many centers are transitioning to this methodology for varied reasons that will be covered in another chapter and topic. SEG, though, is not merely a depth electrode technique. It's not just a way of placing depth electrodes, but it is a methodology in itself, aiming to describe epilepsies and seizures in the spatial temporal sense, and how they organize in the brain in the epileptogenic zone. So the concept of the anatomo electroclinical hypothesis, I've mentioned a few times now, really comes from this methodologic framework, though one still needs an appropriate pre-surgical hypothesis for a subdural grid evaluation. The major drawback with SEG is a situation where one needs contiguous sampling of eloquent cortex. So, for example, language cortex, it's much more difficult to achieve that, and certainly not with the same resolution that one can obtain with a subdural grid. This diagram is meant to indicate the preferred invasive method in certain situations, and the first point is that one needs a sound electroclinical hypothesis in order to appropriately plan the study. In a situation where the MRI is negative, or there's no relevant lesion identified, SEG is the invasive method of choice, and the one that we would certainly suggest. In the situation where the MRI is positive and shows a lesion, and if that lesion is in non-eloquent cortex, very often no invasive method is required. Many of these patients will be able to have a direct surgical intervention should the data prove convergent. Which is to say, in some cases, they still may need invasive methodology if for whatever reason the data do not converge or there's some strong discordance. The situation where there is a lesion in eloquent cortex is the one where subdural grids is most relevant, and it's really the only one, I think, where the technique is preferred, and that is again because of the ability to sample and map in a contiguous way of functional regions, and especially language areas. If there is a lesion at the depth of the sulcus, SEG is preferred. Now, if it's a bottom of the sulcus dysplasia, like in the example I showed earlier, direct resection with intraoperative monitoring and electrocorticography is perfectly reasonable, and there have been some well-performed studies that have suggested that approach. The situation where there's more than one lesion, especially lesions that sit in both hemispheres, is certainly better approached through an SEG framework. And then finally, if there's a lesion situated in a deep area of the brain, the insula, the cingulate, for example, would be better studied by SEG. So in summary then, pre-surgical evaluation of the patient for pharmacoresistant epilepsy can be largely accomplished by non-invasive techniques, and the ones that provide the most support are clinical semiology, video EEG recordings, high-resolution MRI, and then neuropsychology. So these are used for in all patients, and in many patients will be sufficient to formulating a surgical strategy. I went through briefly some of the ancillary techniques, not at all an exhaustive survey, and other techniques we've mentioned in other chapters. And then invasive evaluations are needed in some cases. We went through that, and with SEG being the preferred method in most situations.